appointments, as well as view the medical history entered by the patient or the paramedics, and start a consultation with the patient, and then upload the diagnosis and a prescription. In the patient module, right now, our paramedics, they entered the patient login with their ID cards, ID numbers, and they see the available doctors on the duty, book appointment, enter the medical history, they upload the medical reports, and on the slot given for them, they start a live video consultation with the doctor, and after the consultation with doctor, we give the patient receives a prescription, digital prescription which can be printed. So this is our main screenshot where the user can log in with their name and password. And this is the admin schedules doctor according to the availability in the hospital. And this is a doctor schedule list. And a patient can book an appointment according to the availability of the doctor, and schedule is slot is given for the patient. And the paramedics can help the patient to enter the common symptoms and other chronic health condition of the patient, and the report that the patient has, it can be uploaded in that system as well. And when after his booking is confirmed, it comes like this. And when the doctor sees, he can see the medical record of the patient if it has been entered. And then after that, we can start a consultation using the TrueCon device software. And this is the final prescription that the patient receives after the teleconsultation. So what are the challenges? We are still in the early phase, and the implementation of the emergency module has been a big challenge for us, as we have only, uh, being a security force hospital, we are only using the intranet connectivity. So we are not using the internet service for our application. So our plan was, when our troops goes out for the emergency response, this application can be used on those scenarios also. But due to the data security and other regions, we are holding our emergency module. And as all other participant has also said that there is a technical glitch in our country due to the connectivity problem and everything. And the challenge I find in our hospital setup is the effective communication between, it is not only run by the healthcare workers, the IT professionals and the patient. There should be a effective communication as well as concern. And patient sometimes hesitate to tell all his problems because there is a privacy concerns. And as well as telemedicine is useful when there's less healthcare worker. But in this our real scenario, we have only 32 specialist consultant doctors working in a referral hospital. So some are deployed somewhere else, some are deployed, and there's always lack of healthcare worker. And the medical medicine supply, this is a unique problem to us, as the patient when visit to our center, if we write medicine, they get free medicine. But when that patient from the outreach area consult with us in telecom consultation is done, if he receives a prescription, he has to buy medicine, and that medicine, his money is spent on that medicine. And in our setup, we don't have a dedicated fund for the telemedicine. All our application and everything was built by our in-house IT experts. And we don't have any formal kind of training in telemedicine as well. And we don't have IT equipments and other high medical gadgets, but still we have started our telemedicine with what we have. So coming to the end, what we think is there should be a comprehensive telemedicine policy. When we started our telemedicine service, the guidelines from the NMC was just document that was available for us. So we followed that guideline and could formulate what we knew. But there should be a comprehensive national policy or a policy from some authority telling that these are the procedures to be done in telemedicine. The privacy concern of the patient should be addressed. The data security, the technology requirement for all this stuff should be addressed. And apart from that, the financial support or a budget allocated for a government hospital like us to run a telemedicine, there should be a budget allocated for these kind of services. And we also think that we should increase awareness not only to the healthcare worker, also to the patient on using these kind of virtual healthcare services. And hospital personals, not only the clinicians, the support staff, IT personals, all should be trained about the use of this kind of platforms. And to us, the wider reach of adequate bandwidth intranet service across the country might help us to spread out telecommunication round across the country. Thank you very much. And this is the picture of the recent SARI Facility Center that was inaugurated in our center. It was handed over by MOSP to us in this week. Thank you very much.
Thank you so much. Now, I would like to introduce Dr. Ramesh Kandel, titled Geriatric Telemedicine, a newer dimension of care for older people. He also served as a consultant in WHO Southeast Asia Regional Office. Before he joined as a consultant in healthy aging at WHO, Shero, he founded the first department of geriatric medicine in Patan Academy of Health Science, Lalitpur, and worked as assistant professor of geriatric medicine there for 5 years. He's also involved in various communities working for geriatric health and social service under Ministry of Health and Population, as well as Ministry of Women, Children, and Senior Citizen in Nepal. Dr. Ramesh is also a technical advisor to various NGOs working in the field of aging in Nepal. Dr. Ramesh Kandel, the first registered geriatrician of Nepal, serves as a medical director as well as associate professor and head in the Department of Medicine and Geriatrics at Rapti Academy.
Namaskar, and a very good afternoon to all of you. It's my privilege to be a speaker in this prestigious forum. At first, I would like to thank the Telemedicine Society of Nepal for this opportunity, and especially Dr. Uday. So to start, I'm going to start my presentation. I hope my slides are visible. Okay. Today I'll be talking about a newer dimension of care for older people. That's geriatric telemedicine service. It would be a new concept for a few of us who are around here. So at the outset, I would like to express there is no conflict of interest with this presentation. Talking about the benefits of virtual visits for older patients and their caregivers, there are so many benefits. One of the benefits would be like fewer trips outside of the home. As we know, in Nepal, now we are getting into nuclear family. The older joint family system has been disintegrating, and that has been equally applied to urban as well as in the rural sector, where the older people, the older clients are alone in their home, just supported by their spouses. So there's very difficulty in negotiating through the health system. There is a problem with transportation, going out of the house. And there is also another advantage of telehealth, that would be less exposure to infectious diseases like COVID-19 and others. Now we have an epidemic of influenza going in various parts of our country. So the telemedicine or telehealth would be another opportunity to grow in such scenarios. Similarly, there is a problem of getting appointments in tertiary care centers. So if telemedicine is widely implemented, there is better chances of being solved sooner, and there are no additional costs involving transportation. And when you go to tertiary centers, there are issues of livings in hotel or somewhere else. So there will be no additional cost involved. So there are so many benefits which are with regards to telemedicine or telehealth services, especially when we talk about older patients. So what would be the scope of telemedicine service for older people? There are various dimensions of health which can be addressed by telehealth services. One would be like health promotion and disease prevention. Like one of the measures would be health counseling, which is quite of paramount importance to the life of older people. We can talk about exercise modalities. We can talk about vaccination. We can encourage our clients for getting vaccinated. We can advise for nutritional issues like what to take and what not. We can engage the dietitians. So many things can happen with the aid of telemedicine services. Similarly, we can help in curative services, especially in terms of counseling. That can be of paramount importance. Similarly, another dimension of care, which is also a part of long-term care for older people, that's the rehabilitative services. So we can offer physical therapy as well as occupational therapy by means of telemedicine and telehealth services. So there is a wide scope of telemedicine with regards to older people. So what could be certain prerequisites for treating older people through telemedicine or telehealth services? Like understanding whether our clients are digitally literate or not, whether they have a basic understanding of how these devices work, that is of paramount importance. Similarly, considering non-video telehealth options like using phone calls or using emails in case of educated older people, that can be another option. And giving extra time during the first telehealth appointments with older clients is of paramount importance. So because the older people, when they talk to you, you have to give so much of time to figure out what's the actual problem in those patients. It might not be so easy like serving a 30 or 40-year-old gentleman or female with health issues. Addressing older people with health issues is a very challenging aspect, and it's indeed an art. So during the first telehealth appointments, it's very important to give them ample opportunities to express themselves out their illnesses. And similarly, there can be use of remote monitoring devices such as blood pressure monitors, heart rate monitors, glucose monitors, and compiling vital information from these patients. So there are certain requisitions like preparation when we talk about telehealth or telemedicine appointments with older clients. That can happen both in the home as well as the institutional settings. Like we need to assign a staff member from our telehealth group for walking them through their home setup, because when we talk about geriatric medicine, we have to talk, it's very important to talk about the home environment in which those older people are residing, because that has a profound impact on their health. Similarly, reviewing technology basics through the employed staff member is also important. You can also think of audio-only or phone-based telehealth appointments, especially for semi-literate or illiterate clients. Similarly, getting additional help from caregiver or family member is very important when we talk about older clients, because they might have sensory impairments in terms of hearing deficits with regards to vision deficits. So the engagement of caregiver or family member during teleconsultation is very important if we wish to get exact data or exact information from our patients. Similarly, when we counsel the patients, if the patients have cognitive impairment or sensory impairments, then it's very essential to have bystander. So with regards to telehealth, telecommunication, teleconsultation, or telemedicine in Nepal, there are so many challenges. Like digital literacy among older adults is a very important issue that we have to ponder on. Like various studies have shown that worldwide only 40% of older people have access to digital communication strategies. So I think if we talk about Nepal, much of the older people, especially who are in their 80s or 90s, might not have even seen mobile devices. Getting into like desktops or laptop is a very distant thing for them. So we have to be very careful about whether our clients have digital literacy or not. Similarly, availability of telecommunication technology, like if we get out of Kathmandu, we can say if we get out of Nagdunga, it's very difficult to get access of NTC, which is a prime telecommunication network in our country. So these all are usually urban centers. So what about the rural clients, people living in the rural areas of Nepal, whether the telecommunication or technologies are available or not? That's another major concern. Similarly, affordability. is other major concern, like the data cost in Nepal is one of the most expensive in Southeast Asia, in almost we can say in Asia. So whether this comes under the affordability of those older clients or not, who have poor economic base. So that's another major concern. Similarly, lack of geriatric friendly communication tools. Now we find it very comfortable to use smartphones with touch technologies, but whether these are really friendly to our geriatric clients or not, that's another aspect we have to think about. Similarly, there are policy related constraints which have acted as major barrier for implementation of telemedicine services for older adults in Nepal. So there have been various studies. We have assessed the satisfaction with telemedicine during the COVID-19 pandemic. We have after COVID-19 pandemic, telemedicine has come into a limelight. So this was a publication in the Journal of Telemedicine and E-Health. It was published in 2023 January. So they have assessed various factors which have influenced patient satisfaction with telemedicine, and there are system-related factors, patient-related factors, socioeconomic factors, and nature of medical intervention. Like, so we have to think because this is quite challenging in the context of Nepal, where there is a lot of topographical variation, literacy variation, and so many issues. So we have to think in a holistic manner when we talk about telemedicine, especially with regards to older adults in Nepal. So what is missing from telehealth visits? Most importantly, the ease of use. Like, technology may not work like what it is supposed to work, especially with regards to older people. That means one of the major issue with regards to telemedicine, the time issue. Telemedicine feel rushed. Like Dr. Uday has allotted me 10 minutes for this presentation, but I'm always like in apprehensive whether I can finish this presentation within that span of time or not. So older people, we have sensory impairments, hearing impairments, visual impairments, poor health literacy, poor digital literacy, whether they will benefit from telemedicine or not. That's one of the major issues we have to think upon. Similarly, rapport. Telemedicine, telehealth may not have that emotional component of care, which is always present when we are sitting by our patient side to side, the touch, the eye contacts, and so many things, the communication related things, which are of paramount importance when we talk about geriatric care. And will that really be possible through telemedicine or not, telehealth or not? Like, it is said that telehealth is not as intimate as it is like in-person appointments. So these are the things which might have, which might affect the efficacy of the effectiveness of telemedicine services. So when we talk about telemedicine service with regards to older adults, we have to think of these components of intervention as well. So while sharing about what is happening with telemedicine at Rapti Academy of Health Sciences, to introduce Rapti Academy of Health Sciences, it is one of the youngest academy, health academy under the federal government of Nepal. It is situated in Dang district. As we know, as you might know, Dang district is one of the semi-rural, or we can say semi-urban district situated in Lumini province. So here we are, as a medical director, I feel privileged to share this information with you. We are in the process of studying telephysiotherapy. So we have been collaborating with Handicap International. The devices are already in place, and we'll be implementing this service in a very near future. Like, the physiotherapist at our center will be coordinating with the health assistants, and we can say aged the health workers in the satellite peripheral hospitals. Like, we serve the patients from Rukum, Rolpas, Fallan, Putan, and Dang. So there will be installation of telephysiotherapy mini centers at the surrounding districts, and there will be a referral telephysiotherapy center at Rapti Academy of Health Sciences. The physiotherapist here will be in connection with the health workers in the peripheral telemedicine centers, and they will be instituting telephysiotherapy. So we are very thankful to Handicap International. We have been very pivotal in installing these services. So from the very new year that starts from Baisak 1, so we'll be going into full-fledged manner. We'll be starting telephysiotherapy services, and we are hopeful that the especially the bed-bound patients or patients who might be requiring intensive physiotherapy and occupational therapy in the neighboring districts, who might have a lot of logistic issues to visit Rapti Academy of Health Sciences from these neighboring hills, might be quite might find it quite beneficial for the improvement of their holistic health. So talking about way forward with regards to telehealth or telemedicine with regards to older adults, we have to be more thoughtful about the digital literacy for older adults. We have to think of manners by which we can improve digital literacy in these older adults. So we can give good access. The older clients will really be benefited from this. It's important in other way also, because now when we are talking about nuclear family system in Nepal, where the offsprings are quite at a distance from their parents, for other reasons, for like decreasing the intergenerational gap, and for intergenerational solidarity also, improving digital literacy among older adults is of very importance. Similarly, availability of digital technology at an affordable price and in various geographic locations would be of another aspect we have to be thinking about when we talk about telemedicine or telehealth with regards to older adults. With this, I would like to end my presentation. I am very thankful to Telemedicine Society of Nepal, Dr. Uday, and you great listeners for your time and attention. Thank you so much.
Thank you for all the speakers. Now the floor is open for the questions and comment. Please. Yes, please.
My question is for Dr. Rajkumar, Dr. Sailendra, and Dr. Ramesh, all three speaking doctors. As a doctor, are you confident enough with the given guidelines by Nepal Medical Council? Are you confident enough in delivering the care through telemedicine modality or not, particularly because of the signature and documentation issue? And yes, the question goes to NREN General Secretary as well.
Thank you, Subhas, for the question. In our prescription, we have given a digital signature of ours. So what we think is it's permitted by the NMC guideline, but the only NMC guideline, it cannot be the judge everything for the telemedicine. So that's why we said there should be a comprehensive telemedicine policy incorporating the IT departments, MOHP, and other sectors, stakeholders. This should be a complete package. Telemedicine is not only for the medical doctors. So what I think is that NMC guidelines will somehow give us a guideline, but overall, there should be an umbrella. Yeah, thank you.
Promise.
Thank you, Subhas, for this question. Yep. So especially with regards to older clients, so what we have been practicing, like client is personally present in our hospital setting or outpatient settings, is a more effective way of communication, because there are so many communication barriers when you talk about older people, especially when we talk about curative services, but especially for like when we talk about rehabilitative services, when you talk about promotive health, preventive health, and counseling, which is of paramount importance, identifying the danger signs promptly, I think this telemedicine would be of great importance. But always when we talk about geriatric patients, we have to be very much concerned about their cognitive level, their digital literacy, their sensory, the issues related to sensory impairments and so many things. So it might not be effective way when we talk about curative health services, but for the other dimensions of health, or other telemedicine would be quite beneficial when we talk about older people, older clients. Thank you.
Thank you, Dr. Shubhas, for a very good question. Actually, like for me, since Dr. Raju said so much about telemedicine, and this from this morning we have been discussing about telemedicine, and now we know how much benefit it has been giving to our general population. So rules should be, amended, and I think there is a saying in Nepal, because of our geography, everything, I think this telemedicine is most in current situation. So NMC is here for us and for people also. So I think we should really encourage NMC to amend this thing in their, rules and regulation things. Thank you so much.
Please, Doctor.
म डाक्टर अरुण नेउपाने टेलिमेडिसिनमा केही इन्ट्रेस्ट र केही अलिकति नलेज भएर आएको मात्रै सिक्नलाई। मेरो दुई तीनटा कुराहरू छ, इट्स ओपन, एनीबडी क्यान आन्सर। एउटा चाहिँ म आई थिङ्क टेलिमेडिसिन सोसाइटी अथवा टेलिमेडिसिनमा काम गर्नेहरूको लागि, सबैको लागि एउटा पेसेन्ट कन्फिडेन्सियालिटी र प्राइभेसीको बारेमा यसमा कहीँ पनि अब कसरी त्यो चाहिँ मेन्टेन भएको छ भन्ने, इफ समवन कुड टेल मी। अब त्यस्तै गरी त्यसबाट आएको डेटा र कुन सर्भरमा जान्छ, कुन देशमा गएर बस्छ र डाटाहरू चाहिँ कसरी बाहिर गइरहेको हुन्छ, हामी कहाँ चाहिँ हु इज द वाच डग यो टेलिमेडिसिनको सबै चिजमा, यसमा हु इज द वाच डग, मेरो क्वेसन एउटा। दोस्रो क्वेसन इज सबै चिज आयो, युज अफ ग्याजेट चाहिँ एउटामा मात्रै आएको थियो, ग्याजेट्स र इक्विपमेन्ट, स्टेथोस्कोप, थर्मोमिटर्स, सेन्सर्स, इसिजिज भन्ने एउटा प्रेजेन्टेसनमा त आयो हैन, धुलीखेलकोमा है। यो डायग्नोसिस र ट्रिटमेन्टको लागि यसको युजको बारेमा चाहिँ हामीले त्यति सुन्न पाएनौँ आज, यसको इम्पोर्टेन्स छ कि छैन। र लास्टमा चाहिँ टेलिमेडिसिन भनेर हामीले भन्दाखेरि यहाँनिर धेरै मिक्स भन्नु कि मिसम्याच त नहुनु, मिक्स्ड भयो यो एचएमआइएस, यो रेफरल सिस्टम, डिजिटल हेल्थ, टेलिमेडिसिन होइन, यो कतैवटा के गरेर चाहिँ मिलेर अब यसलाई हामी सबैलाई टेलिमेडिसिन भने हो कि, यो मैले चाहिँ अलिकति ज्ञानको लागि सोधेँ है, मैले कसैलाई चेक गरेँ होइन, कि यो कसैले डायग्नोसिस कोही पेसेन्टले नै गर्ने, आइडियली अब खोइ अलिअलि हामी अलिकति कन्जर्भेटिभ सोच गर्दाखेरि चाहिँ हेल्थ टु हेल्थ पर्सनल भएपछि मात्रै पेसेन्ट आउने भन्ने मलाई फिलिङ थियो। पहिले हेल्थ पर्सनलाई रेफर गरेर त्यसको इन्फर्मेसनहरू सबै आइसकेपछि अनि इफ रिक्वायर्ड पेसेन्टसँग इन्टरेक्सन गर्ने हो। अब हामीले सिधै पेसेन्टसँग गर्दाखेरि आई डोन्ट नो, अब इट बिकम्स मोर एन्ड मोर कम्प्लिकेटेड। सो तीनटा चिज, कन्फिडेन्सियालिटीको, यो डेटाको बारेमा, अनि यो ग्याजेट इक्विपमेन्टको, र अनि लास्टमा चाहिँ यो सिधै पेसेन्टसँग गरिहाल्ने हो कि एक लेभलमा प्यारामेडिक अथवा हेल्थ पर्सनसँग गरेपछि मात्रै पेसेन्टसँग गर्ने हो, यति क्लियर भयो हुन्थ्यो। एनीबडी, ओपन फ्लोर, थ्याङ्क यू।
डाक्टर अरुणले एकदमै रिलेभेन्ट प्रश्न राख्नु भएको छ है। मलाई लाग्छ कुनै पनि ठाउँमा हामीहरूले टेलिमेडिसिनको नाउँमा अथवा इ हेल्थको नाउँमा जेसुकै नाममा पनि यो प्र्याक्टिस गरिराखेका छौँ भनेर भनेदेखि प्रविधिको उपयोग गरेर डाक्टरकै छेउमा नभएको कतै टाढा भएको कुनै व्यक्तिलाई अथवा कुनै कम्युनिटीलाई प्रविधिको माध्यमबाट उनीहरूको स्वास्थ्यका समस्याहरू समाधान गर्न हेल्प गरिरहेको छौँ भनेदेखि मलाई लाग्छ त्यसलाई टेलिमेडिसिन भन्ने हुन्छ। इ हेल्थकै एउटा पार्ट होला त्यो। अब अरू जति पनि प्रश्न गर्नुभयो त्यो हामीहरूले प्र्याक्टिस गर्दाखेरि टेलिमेडिसिन नै भनौँ अहिलेलाई अथवा इ हेल्थको प्र्याक्टिस गरिराख्दाखेरि हामी यतिखेर कुन अवस्थामा छौँ, विकासको कुन चरणमा छौँ भन्ने कुरामा चाहिँ भर पर्ने हुन्छ। कुनै कुनै बेलामा अघि बिहान पनि मैले भनेको थिएँ, जब यो चाहिँ नि कर्मकाण्डले जब धर्मलाई हाइज्याक गर्छ नि, when the rituals start hijacking धर्म, त्यसपछि प्रब्लम हुन्छ। र त्यो भएको कारणले गर्दाखेरि मलाई लाग्छ यो कुरा अघि मेडिकल काउन्सिलको कुरा आयो। मेडिकल काउन्सिलले कर्मकाण्ड बुझ्छ, धर्म बुझ्दैन, आवश्यकता बुझ्दैन। त्यो उसलाई गाह्रो पनि हुन्छ होइन। सजिलोको लागि हो नि त। We create formulas, we create rules and regulations, we try to generalize. That's because, for our own comfort, to make things easy for ourselves, not to fulfill the needs of the people. And sometimes, therefore, sometimes maybe if we are going to save life, sometimes we need to take the risk. If we really want to practice love and compassion, we are always afraid what medical council is going to do. I may be behind the bar. Then the best thing we can do is just to run away. Leave the patient in there, lying there in the pool of the blood. Sometimes we need to take the risk. At the same time, I am very much aware that we, the doctors, now I'm not practicing at all, whether I qualify to call myself a doctor now, but many Nepali doctors, they have been mishandled by the patients or the patient parties. That's another issue. That is totally another issue. That's because of the stupidity, foolishness of the government, because they are incapable. We have been choosing useless governments for decades. That's totally another issue. The security, we cannot guarantee our security by fighting the patients or patient parties. But if we really want to, practice love and compassion, we have to take some risks. Unfortunately, in many countries, including ours, where the government is useless, the doctors have to take larger risks, greater risks. That's very unfortunate. That's my understanding. Thank you.
Thank you, Dr. Saab. Dr. Saabले उठाएको तीनवटा क्वेशन्समा एउटा क्वेशन्स चाहिँ मेरो आफ्नै सेक्सन पनि भएको हुनाले मैले डेटा सेक्युरिटीको कुरामा हाम्रो पब्लिक हेल्थ एक्ट भर्खरै ले अब क्लियरली DOIT ले र त्यसपछिबाट आएर IHMS ले जुन मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसन ले जुन पब्लिक हेल्थ एक्टमा जसरी तपाईहरु हामीले पेपरमा डेटा सेक्युरिटी गर्छौं त्यही हिसाबले सिस्टम अल्टिमेटली डिजिटल हेल्थ भने पनि पेपर बेस्ड हेल्थ भने पनि माध्यम मात्रै फरक हो, कानुन त एउटै हो। त्यसकारणले त्यो कानुनलाई ड्यू रेस्पेक्ट दिएर जाँदाखेरि तपाईले चाहे क्लाउडमा राख्नुस् चाहे तपाई आफ्नो होस्टमा राख्नुस्, सर्टेन त्यसको सिस्टमको नर्म्सलाई तपाईले फलो गर्नुभयो भने प्राइभेसी स्ट्यान्डर्ड त डेभलपरले फलो गर्नै पर्यो। त्यो डिचेस राख्यो भनेदेखि त त्यो कानुन एट्र्याक्सन भइहाल्छ त्यहाँनिर। हामी अहिलेको नर्मल कानुनले पनि त्यसलाई काम गर्छ, त्यही कहीँ जानु पर्दैन पहिलो कुरा। दोस्रो कुरा के हो भने टेक्नोलोजीको हिसाबमा हामीले जुन अहिले प्र्याक्टिस गरिरहेछौँ डाइरेक्ट पहिले पनि 10 वर्ष अगाडि डाक्टर सञ्जिता र हामीसँगै नेपालमा काम गर्दा एउटा क्वेसन्स एकदमै हामीले सँगै डिबेट भइरहेको थियो डाइरेक्ट पेसेन्टलाई काठमाडौँको डक्टरले डाइरेक्ट पेसेन्टलाई डिल गर्दाखेरि त्यो रुरल एरियामा काम गर्ने डक्टरको भ्यालु के हुन्छ एकदम सिरियस यो चाहिँ सिरियस क्वेसन हो टेलिमेडिसिन प्र्याक्टिस गर्ने नाममा कतै रुरल हेल्थ वर्करलाई युजलेस त बनाउँदैनौँ हामीले सिरियस क्वेसन छ र यो सिरियस क्वेसनलाई हामीले पब्लिक हेल्थ एक्टमा यसपालि एड्रेस गरेका छौँ सकेसम्म हेल्थ वर्कर डाइरेक्ट जो पेसेन्ट जो डक्टरसँग एट्याच छ त्योसँग पहिलो ओनरसिप उसैसँग हुन्छ उसकै रेस्पोन्सिबिलिटी हुन्छ यदि उसलाई ट्रिटमेन्ट गराउने हो भने तपाईँले इम्पावर गर्नु पर्यो डक्टर टु डक्टर एउटा हाम्रो उसले पनि भनेको छ त्यस कारणले गर्दाखेरि थोरै हाम्रो डेफिनेसनहरूलाई सच्याउनु पर्ला त्यो थोरै उसमा काम गर्नु पर्ला होइन भने मलाई जहाँसम्म लाग्छ मान्छे मर्न रेडी छ भनेदेखि हामीले यहाँ होइन जोसुकै नर्थ कोरियाको डक्टरसँग एक्सेस लिएर भए पनि बचाउनु पर्यो हामीलाई त कुनै रेस्ट्रिक्सन जियोग्राफिकल रेस्ट्रिक्सन कुनै रिजनल कुनै पोलिटिकल कुनै पनि कुरा ल्याएर किन भन्दाखेरि मान्छेको लाइफ धेरै त्योभन्दा धेरै माथि छ त्यस कारणले गर्दाखेरि टेक्नोलोजीको अवसर हामीले युज गर्नुपर्छ जुनसुकै अवसरमा युज गर्नुपर्छ डेटा सेक्युरिटीको डेटा क्लियर रूपमा कानुनमा कहीँ पनि मैले ग्लिचेस देखाएको छैन किन भन्दाखेरि तपाईँले हामीले दिएको कानुन अनुसार भोलि सरकारले तैँले किन यसो गरिस् भनेर कसैले सोध्यो भने एन्सर दिन सक्नु पर्यो त्यति हो अरू केही पनि छैन मैले यति नै भने हस् थ्याङ्क यू
Thank you for excellent answer. I think now, Doctor.
Thank you. अरुण डाक्टर साहबले उठाउनु भएको कुरा एकदम जायज जस्तो लागेको छ जायज हो र सरोज डाक्टर साहब र उहाँले भन्नुभयो धेरै कुरा त क्लियर गर्नुभयो र हामी टेलिहेल्थसँग टेलिमेडिसिन अलिकति कन्फ्युज कहिले पनि यहाँ चाहिँ नि हामी टेलीको कुरा गरे पनि टेलिमेडिसिनको कुरामा टेलिहेल्थ वेल्थ पनि आउँछ टेलिहेल्थ भनेपछि त
एउटा रिक्वेस्ट आएको छ if we speak in English it will be convenient for others also.
Okay, thank you. Just now a few questions were raised regarding the how ethical it would be to treat patients directly through telemedicine, talking directly to the patient and prescribing medicines to patients directly. So far, it might be in practice somewhere. But as far as I know, from the government point of view, because I was kind of working with the government also, just recently, even now I'm working with the government. I'm trying to develop telemedicine software for the patients, to how to take care of them. And especially at this time, we have designed telemedicine through district hospital. A specialist from the hub hospital would talk or communicate with the doctor from district hospital, not directly to the patient. But if we want to see the patient, then it would be seen through the local doctor. That was a big issue. We do not want directly to talk to patient and treat. That was a big issue because from the government point of view, they have to do it. Before they do, they have to be really careful. So that was very well thought, Dr. Arun raised that question. So we have already seen, and in the market, we see so many equipments. You just put somewhere, it will give glucose. We just wrap around this, it will give blood pressure. How authentic, how nice it would be, how useful it would actually be, that we don't know. But so far, patients should be treated through medical practitioner. That would be the best practice, you know. So I think that's the way it should be done. Thank you.
Please.
Sorry, there is so much time constraint, but I just want to speak a small thing about that. I connected telemedicine, digital health and ML. So I would just like to add one point, like I'm also naive in digital health and telemedicine actually. But I think e-health, like telemedicine comes under electronic health. And then what we have been doing from the Delhi hospital is we develop clinical electronic decision support system for the frontline health worker. And that is developed with evidence, with a reference from the national protocol. So just like we get everything, algorithm, guidelines, everything we develop, whatever that is being developed in the mobile phones is reference from the national protocol. So why not develop the algorithms and this type of clinical decision support system that will be in the hand of the frontline health worker in the rural settings, just like auxiliary nurse midwives, health workers, and auxiliary health workers, so that they can directly connect to the great doctors in maybe urban areas and get consultation and like revised trainings with the proper guidelines that will be in the hand of the people in the rural settings rural settings, so that they can rely on that guideline and give the treatment as per national protocol. So that's the only thing I wanted to add. I think this is the part that have to be brainstormed not only from the stakeholders, from the national government and worldwide also, because we believe in evidence-based medicine. Thank you.
Okay, thank you. Very important interactions. Finally, we'd like to thank all the speakers and interacting participants, and we chairpersons also would like to thank Dr. Uday and Telemedicine Society for giving us this opportunity. Thank you.
Thank you, Vishnu sir and Dr. Sanjeev. So with this, we come to the end of the session 3. Now we move to session 4. We have a felicitation program. I'd like to hand over the mic to Dr. Uday.
Thank you. आज यो एकदमै हाम्रो चाहिँ टेलिमेडिसिनको लागि उत्सव नै जस्तो लागिरहेछ। सबैजना मेरो सिनियर गुरुहरू सबैजना चाहिँ यहाँ उपस्थित हुनुहुन्छ। मलाई एकछिन अलिकति 2 शब्द चाहिँ नेपालीमै बोल्न मलाई यो खुसीको क्षण भयो भएर साह्रै नै खुसी लागेको छ। सो आई एम रियली भेरी ह्याप्पी द्याट माई अल द सिनियर्स आर हियर। It's great honor to form Telemedicine Society. It was a hard time. Members sir must have so hard time to establish telemedicine, to talk about telemedicine, and to say that it's the future. It's the future of the medicine. And how difficult it would have been to convince the people. Similarly, I can see Muniraj sir here. So all the ages he has worked in science and technology, in health. He has a museum, Science and Technology Museum in Kazakhstan, and he has been working so hard to establish digital, and he's so happy. It's passion for him to develop digital health in Nepal. And similarly, my guru, Saroj Hital sir, he has been working. It's because of him. It's because of his inspiration that now I'm also in the field of telemedicine, in the field of digital health. Similarly, we have Narendra sir online. Narendra Bhatta, he has been working hard in Bhutan, BPKIHS, to establish telemedicine services in eastern part of the community. Similarly, Dr. Vishnu Dattapaudel is here. He has established telemedicine services in Veer Hospital. And he's always so happy whenever I call him. So there is some program of telemedicine. He's always ready, always ready. So thank you, sir. And I can say Arun sir, actually he knows everything. He was asking as if he doesn't know, he knows everything. And so, and because he had worked so hard in CCMC, we all know that. And similarly, I can see Rajendra sir, he was working all the way to the to Magdi Nagi with Mahavir sir in Wireless Nepal to establish
those wireless connections in the trees, the pillars, in the roof of the houses. Now they are like stories, but they are realities. They are realities. And we have to realize that it was not an easy task to establish, to go on. And maybe our younger generations won't realize how difficult it was, but still we can feel that pain. So that is why we have planned to have this felicitation program today. So thank you, sir. Thank you, all of you. And we have other members also, like Dr. Bhushan Raj Shrestha, who is in Nepal Research Education Network. He is busy down in APAN conference. Similarly, Mr. Lochon Lal Amatya, sir. They all, even in IT, they are not in health, but they have known better health than us. So that is the thing that they are always pushing. And they are always very happy. So I'm very glad to have my gurus like this. I call them VIP, very important person, but if you see other leaders, so they are like this, and our teachers are always like this. So thank you, sir. Thank you very much. Yes, and Dr. Pradeep Vaidya, sir, he has been working hard in TUTS. I don't see him. He was here in the morning. So all these are our great gurus. First we will hear from Dr. Narendra, sir. He is online, and then we'll start the felicitation program. Dr. Narendra Bhatta, sir.
Yeah, thank you, Dr. Uday. Thank you very much. Firstly, let me congratulate you and the team of Nepal Telemedicine Society for conducting this nice, wonderful session. I wish I could have come and joined personally, but due to certain unavoidable circumstances and my own assignment, I couldn't come. I acknowledge the gratefulness that the felicitation program, and now I think it's a new era of telemedicine. It's a new thing. It's a future of the health in Nepal. And telemedicine, one has to serve the country, the people through the telemedicine and digital health, and its time has already come. Thank you very much. Thanks a lot.
Thank you. Thank you. Now I would like to request Dr. Tomohiko Moriyama. He is Director of Telemedicine Asia Development Center of Asia, and he has been helping us a lot to establish telemedicine, to develop telemedicine, and they have been pushing that, okay, this is the way to go. We must go together, and they are hand in hand. And they always say that we also should learn from Nepal. That is great thing, that Japan also should learn something from Nepal. That is good thing. So we are learning a lot thing from them. So thank you, sir, for being here. So I would like to request him to honor our Dr. Mingmar Sherpa. We will give the certificate. Open this. Open it. Certificate. Thank you. म एकचोटि यो पढेर सुनाउन चाहन्छु। नेपाल टेलिमेडिसिन सोसाइटी सम्मान पत्र। यहाँले नेपालमा टेलिमेडिसिनको विकासको लागि गर्नुभएको अथक मेहनत र प्रयासको उच्च सम्मान गर्दै नेपाल टेलिमेडिसिन सोसाइटी साथै नेपाल रिसर्च एन्ड एजुकेसन नेटवर्क तपाईँ डाक्टर मिङमार शेर्पाज्यूलाई यो सम्मान पत्र प्रदान गरिएको छ। धन्यवाद। अब मिङमार सरले नेक्स्ट उहाँले दिनुहुन्छ। हस् म डाक्टर विष्णु दत्त पौडेललाई बोलाउन चाहन्छु। डाक्टर विष्णु दत्त पौडेल उहाँको पनि परिचय चाहिँ होला। अहिले भक्तपुर क्यान्सर अस्पतालमा चाहिँ मेरो अस्पतालमा Yeah. Thank you, sir. Was around sorry, next. Sorry, next slide. अब म डाक्टर सरोज धिताल सरलाई बोलाउन चाहन्छु। सरोज धिताल सरको पनि परिचय खासै चाहिँ हुनुला, यो टेलिमेडिसिन र डिजिटल हेल्थको विकासको लागि उहाँले गर्नुभएको प्रयास दोस्रो धन्यवाद। मुनिराज साके सर। मुनिराज साके सरले पनि धेरै नै यो डिजिटल हेल्थमा उहाँ पनि आइटी इन्जिनियर र पहिलेदेखि डिजिटल हेल्थमा धेरै so yes, धन्यवाद। अब नरेन्द्र सरलाई हामीले अनलाइन नै सम्मान
Thank you very much, Dr. Uday. Thank you very much. I most humbly and appreciate us. Thank you very much.
त्यस्तै गरी महावीर सर चाहिँ मलाई त्यो सम्मान हो भने म भागिहाल्छु भनेर भन्नु है। उहाँ अलिकति चाँडै निस्कनु भयो, अलिकति व्यस्त हुनुहुँदो रहेछ। त्यस्तै गरी डाक्टर भूषण डाक्टर के अरे लोचन सरको एकछिनमा आउनुहुन्छ होला, त्यसपछि हामी गर्छौँ। अब चाहिँ हामी टी सेसन गर्छौँ। Then we'll start. After 15 minutes, we'll start the next session. Thank you.
Thank you. Thank you very much. Thank you.
I say a few words here. Maybe this will be. Well, here I see all the doctors, but I am not. I'm simply an engineer. This really encouraged me so much. I'm talking about 2008, 2009. That's when we, with a group of doctors, and myself, an engineer, we started this telemedicine service. Way out in Kalikot. You must have heard of the story that then, around that time, 307 people died, one after another. You know how they died? Simply, Tarabakala. That's a dysentery, diarrhea. Just the diarrhea took 307 people's life. That hit me hard. That was a breaking news. That hit me hard. I just wished I was a doctor. I just wished I could go to that Kalikot, that Jajarkot actually. That's where it happened. I wish so many, but I must do something to save the life. You can do many, many things in many different faculties, but saving a life of someone is the prime duty of anybody, anyone, anywhere in the world. I must do something. How do I do it now? I had just developed something. I had a green computer. Then, we had a blackouts. Blackouts, 18 hours a day, 16 hours a day, no light, nothing. So all the computers were dead. Even Mahavir Pun, he asked, then that was the time I made a green computer. Green computer is the computer which only works on 35, 30 watts. So during that time, when there was no power, this computer has saved so many things. So my attention went to these people who are dying. This is the time I must do something. How do I start? I have no idea how do I start. Anyway, I got a bunch of doctors from teaching hospital. They just had their MBBS. I approached them, and a group of them came over to my place. I had a telemedicine kind of thing, but it was a computer. One is somewhere. I said, there's a sick person. There are, I think, 8 or 10 doctors. Dr. Said already, you save the life of someone who is somewhere. The picture you will see just now. So I had a picture in the monitor. A girl was almost dying. Doctors, please try to save this girl's life. So how to do that? So they asked few questions to that girl. It came in the screen. So they asked few questions. What happened? What is the problem? Do you have fever? All this medical, terminology. So they gave some answers. They asked questions, and the girl gave answers. They were given some medicine. The girl's life was saved. Like that, in Calicut, people were just dying one after another. Something, small things happened. Some people just fall down from the street, broke the hand. Something can happen any time. That's a place in Calicut. There were no health posts. There were no doctors around. Nobody. How to do in such a remote place? How do you do any business in the health sector? So these doctors. Doctor, you don't have to go to Calicut. You don't have to go to Jajalkot. You be here one day. See the system here? I showed you the girl's picture. This is how we do it. Okay? So from there we started in Calicut, all the people came along. And a surrounding area, people started coming one after another. Just because they have no service whatsoever health-wise. So that's how we did our job. We had a mobile set just starting to come. We only had 9K. That's a small bandwidth, but we could do the video conferencing with that, thing. So we started on and on and on. Every time people come, they lined up. The people heard from nearby areas, hey, there is some service. Telemedicine, they said, telemedicine. So they lined up. Some people came walking 3 days. They rested on the way, Dokumambogara. They carried on the back. 3 days they came and came to this Calicut station. We saved their lives. This is how I just wanted to share with you, all these happy moments in my life. I've done so many other things, but this one is the most important thing in my whole life. I have done something. Thank you. Thank you.
Uh, Okay, thank you. After lunch and then a long session, then after tea. So everyone must have been feeling sleepy. So now we'll have a hot discussion on how we should go. Actually, Arun sir has already initiated the discussion. So we'll continue to have the hot discussion about the different aspects of telemedicine. And it's my pleasure to introduce Dr. Subhas Pakurel. He's Director of Health Concern Nepal and also Director of Mediflow. So he will be moderating the session. Thank you.
Thank you, Dr. Uday and Telemedicine Society of Nepal. In next 25 minutes, we'll make it very interesting. We'll generate some pinching and punching points to draft the resolution from this esteemed floor. And it's not that it will be rituals, because in 2019, that symposium also generated one resolution, and that was taken as a seed or nidus for generating that guidelines from Nepal Medical Council and from Curative Service Division as well. So the floor is open. We'll fully utilize our experience, energy, enthusiasm all to make this resolution. And we all are of equal weightage with due respect to all the felicitated persons. Okay, first we'll start from the government commitment. Are we satisfied with the level of commitment from government, or there should be some push? So floor is open. Then the first point will be the government's commitment in that resolution. So floor is open. We go constructive, being some level of critical. Okay, Dr. Saros.
Actually, I'm not doing the right thing. I should not have the mic first because I know very little about the government's commitment. But if we really want the government to do something, then we need to understand our own needs. From what we have heard today from different speakers is that we have a number of issues. Before starting to bark at the gate of the government, we should acknowledge that maybe our understanding of telemedicine probably is not very clear among ourselves. Therefore, I suggest that we need to have a working definition of telemedicine. If you like, you can say e-health and telemedicine in our own context. As Dr. Mingma has said, you know, देश अनुसारको त्यही अनुसारको नियम भनेको त्यो अनुसार बनाउनु पर्छ. So what does e-health and telemedicine mean to us? It has got different dimensions. It can be a wonderful earning platform also. And it can also be a platform to, you know, a vehicle to reach the unreached population. What, you know, people who are gathered here, what do we need e-health and telemedicine for? You know, and after that, there are a few things which need to be, you know, clarified. One is that definitely government seems to be not very clear. When the regulations are made, what are the regulations for? Is it for the well-being of the people? Is it for saving lives? Or is it for, you know, just imposing something? There is a saying, I forgot who said that, but that is one of my very favorite sayings, and I used to teach my students and juniors as a mantra. A healer offers love and nurtures the soul. A physician offers concern and treats the body, and orderly glares at the patient and imposes procedures. You know, that applies in clinical medicine. But the same thing we have to think about e-health and telemedicine also. What is it for? What does it mean for us? And how does the government understand it? We have heard from Gandhiji how they are practicing telemedicine in Australia.
Okay.
Telemedicine has helped those remote area nurses a lot. Remote area nurses are saving, lots and lots of life. When Muniratnaji was, not a doctor, an engineer, a passionate person, much older than us also, he was so much emotional, he was so much driven by sentiment that he had to go and save, lives in the Western Hills. So when it comes about saving lives, then should the government still be, what's the government doing? In those conditions, if he had to abide by the government rules, then maybe, many more lives would have been lost. So, okay, that's fine. NMC must have regulations and rules and everything, but that should be stratified. That should be, made in many tiers. For what purpose? What sort of rules and regulations? It's not for, some quacks coming from the, outside the border and doing all sort of nasty things here. They have to be controlled, but the same rules and regulations, if that is, misutilized to control, to block the, speed of the younger generation of very compassionate people who are trying to help people, that will be criminal in itself. That will be the most unethical thing. When you are talking about ethics and, just connecting it to whether the NMC has allowed this or not, and then let people die, okay. What will be more unethical than that? So we have to urge the government to make, their rules and regulations very much, context based.
So floorले एउटा resolution त्यही pass गर्छ पाली endorsement.
The second thing I want to say is that,
please.
This is another, this may not be, this could be a little bit, selfish thing for we doctors, but then whether we like it or not, there should be some sort of standardization of, telemedicine practices so that, we are on the same floor, on the same ground, we are talking about the same thing. And unfortunately, so many groups of people are practicing telemedicine in their own ways, different ways, and that makes things very different. Thank you.
Thank you, Dr. Saroज. Now, उनका अघिकैसँग connected छ तर यसलाई अलिकति separate गर्नुपर्छ होला. Are we sufficient in अघिकै कुरा आउँछ तर यसलाई resolution बनाउनु पर्ने भएको हुनाले are we sufficient in legal, policy and strategic aspects or not? जस्तो त्यो curative service division ले बनाएको भनेको त government ले कुनमा सर्भिस राख्न दिने नदिने कसलाई कति फन्ड allocate गर्ने भन्नेतिर मात्रै लक्षित छ. So what should be the improvement in legal, policy and strategic aspects? त्यो कुरामा एकचोटि फ्लोरबाट केही आयो भने त्यसलाई हामी पास गर्छौं. डाक्टर मिङमार.
Thank you. I would like to speak a little bit about myself. I was 24 years I was in my village. I was there for 24 years in Solukhumbu. I got promoted as a first class officer. There were no posts in my village. So I had to come. I was not very happy to come to Kathmandu, but I came because there were no post for me. So when I came to Kathmandu, I had a lot of patients, my own patient out in the village. So I came up with the idea how to connect with these patients, how to connect with these patients. I went to a computer shop. I wanted to buy a new computer. So I asked him, you have somebody who can do something like this for me? Yeah, I will give you a phone number, this and that. He gave me a phone number. I bought a new computer. And then I asked this guy, look, I have so many patients in the village, how they can just make complaints, other health workers can fill and I can advise them. So I came up with it has to be online, something. So I developed something like Rural Health Online Nepal.
Great. When was it?
That was in the year 2006.
Okay, let's give him a big hand.
2006. At that time, thank you. At that time, I just wanted to connect to my patient. Then later on, when I came to Kathmandu, with the ministry people, this and that, there is one point, okay, telemedicine would be there to provide services to the rural communities, all these things. It was there. So I did not know what telemedicine is. Even then, I did not know what telemedicine is. Later on, I came to know that what I've been doing is a part of telemedicine. So then they asked me, the ministry people asked me, okay, you do the telemedicine thing. So they made me the focal person of telemedicine. Well, I will try my best. I don't have any training. I have never attended any workshop, nothing. I have no idea what telemedicine is. But anyway, I send people all over the district, 75 districts. Are you happy with telemedicine? You want to start this? Do you have telephone? Do you have internet service? Do you have electricity? Do you have a small room for that? I did a survey, one whole year survey. And then finally I found out, I made a presentation of this survey. And then everyone wants to have this, but some do not have internet. Some, there's problem with the electricity, problem with the room, this and that. But we chose the most remote, the 16 districts, the northernmost districts, district hospitals. We chose that. And those days we didn't have any the connection as of now. No. So we bought VSAT. Those days VSAT used to be only for the corporate, some bank or big companies or a big international organization. We bought 25 VSAT and set up all in the mountain up there. Made a little software, the same software, if you have this and that, how to do this and that just. And there is one more thing is video conferencing. Those days, video conferencing everywhere in the world, it was so common. Everybody wanted video conferencing because you want to see patient can see the doctor, is so nice. But later on, they found out that video conferencing is, the store and forward technique is more useful than video conferencing because you need all the data and recordings, all these things. So that's how. So we also did store and forward plus video conferencing. I went to Beer Hospital to set up a specialist kind of clinic. Beer Hospital is it's very difficult. Beer Hospital, there are a lot of people, it keeps changing, you can't do much there. So I went to Patan Hospital. I said, Namaste, Dr. Sahib, let us do this. Can you please provide me a room? So they were kind. They had all these old patient register, all these records, and they removed this, and we cleaned it up. They provided the nice room. We bought computers and set up telemedicine there. We paid around 60 lakhs something per year to Patan Hospital and requested, And then the software was designed in such a way that when the gynae problem would come to gynecologist, surgery problem would come to surgeon. And I mean, similarly, there are 7 or 9 different computers. and you can do video conferencing on one big one like that. So we did that. We set up that, all these different remote these things. And we trained them also. We trained. It was very difficult to train. Even the doctors did not want, they were not, they were happy to visit so many other sites, but when it comes to the telemedicine site, they forget. They forget. We lost the site, this thing. Can you please say it again? It was not at all easy. But still we tried. And later on, it was inaugurated by our Prime Minister, Madhav Nepal. He was invited there to inaugurate this. And he rightly said, okay, Dr. Saab, I'm happy to inaugurate this. As far as the running of this and the maintenance is, I don't know how much it would work, you will say that. So that was 2011. By that time, it was 2011. In 2013, I retired. At the same time, we also got one special number, 1115, something like that, from Nepal Telecom. We requested them, Sola Sati Suna Kunikeke, it's a long one, so nobody is going to remember that. So please give us a very easy number. So they kindly gave us 1115, this number. So toll free. And the Nepal Telecom was going to charge 50,000 rupees a month. We said, okay. And we also went to NCL. NCL, he said, okay, this is for free. If somebody calls from NCL, okay, this is for free because you are doing great. So they were that kind. So we started like that. We put a medical officer 24 hours on duty. The Patton Hospital will put the medical officer on duty.
So based on your difficulty in those era, what will be your suggestion for this resolution regarding this?
Number one, I left and everything collapsed. It is not nice. This is institutional memory should be there.
Okay.
And now.
So proper record mechanisms should be there.
It's a property of the institution, not personal. This is not Dr. Bing Mas, somebody else's, It should be. Ministry of Health has spent so much money on that. And now once this guy goes, everything goes away. It's such a bad thing. And now after so many years, because of the COVID, it has come back again. The president's program of telemedicine should come back, something like that. Then we started again, okay, telemedicine. It is almost 2 years. Every now and then I went to Ministry of Health, curative division, that division, this division. We had so many other doctors from different walks of the police hospital, army hospital, Dr. Pradeep Vaidya. Everybody made a presentation. Okay, what should be done? So everybody had their own little thing. But what we thought is, okay, this is for Ministry of Health. If it was for the clinic, some hospital, and satellite this, and then the story would have been different. But as this is for Ministry of Health, it should be seen in the same way. All the records should be kept permanently. It should be, I requested them, there should be a special department. That the telemedicine is not joke. Nepal is the country who is the most suitable for telemedicine.
Is the small department inside curative service division be sufficient?
No.
Is it sufficient?
No.
Or it should be brought in the ministry itself?
It should be the ministry because curative department is different.
Okay.
It should be different because telemedicine is not that small. As slowly it will even incorporate, it will be together with telehealth, slowly it will be that big. Then it would be very, very big itself. So we need a proper department.
So proper department is required to be
But-
placed inside the Ministry of Health and Population.
Yeah.
So is the floor ready to pass this resolution? Okay. La, एउटा राम्रो resolution आयो. Okay,
And-
so Dr. Rajani, you want to add just something? Okay.
let me-
Last point.
Let me finish
Yeah.
this one. And telemedicine we started finally after 2 years, everyone agreed, okay, this is the way we should go. So we came up with some software. That software consists of something very simple. All the patients admitted at the district hospital, would be looked after by the specialist from the corresponding province hospital or whatever specialty hospital is there. That was how it was designed. That every time I told this is the first step, the very first step of telemedicine. We have to walk so many steps. Now the telemedicine is advanced so much. You can press buttons here and the operation is going somewhere there. We don't want that right now. We have to start something very simple and which is feasible, possible in our kind of situation. And we know what kind of situation we have in the village, in the district, at the Ministry of Health, at this. So then after everything, there was no budget.
So budget should be increased by the government. You open a point.
The budget, right?
Budget is increase and
I went to the minister, health minister, I went to him and explained everything. I made a presentation to the Secretary of Health and his all department, whatever. I made a nice presentation to them. And I said, are you not proud of saying that, declaring that all the patients admitted at the district hospital all over the country would be treated with the help of the specialist? Are you not proud? Would you not be happy to say that? Nobody said anything. I made my presentation and that was the last. That was all. So the budget should be there. This is not just you are not doing it sideways.
Well, we should speak point-wise, I guess, to build the resolution.
Enough budget. There has to be enough budget, not just a little thing, there should be enough budget. So I think that is with that budget, with the proper budget, this should
Thank you.
Thank you.
Thank you, Dr. Minmar, for your elaborated story that touched everyone. Dr. Arun and Dr. Vishnu, you are in some hurry. You have to leave earlier. Can you provide some input for the purpose of creating that resolution? Your input will be of high value.
No, thank you. In fact, the important things has already come. Whatever government is doing is in fact not enough in every context, including the telemedicine also. I think from Dr. Mingma, it was an important topic that there should be a dedicated unit, a team in the ministry to look after the telemedicine and with a dedicated budget also. And it has to be incorporated all the district and zones or regions to provide the telemedicine service, I think. And we telemedicine providing service, not only for service, it can be used for the educational purpose, academic purpose also, and research purpose also. Like basically, I'm using telemedicine more for the educational purpose. Like to run my oncology program, I do have international speakers. They took the classes also. And then for problem management, like another thing which I have been still running is an international tumor board. It's not only that the peripheral people who need the help of telemedicine, even the professor like me, I need help. So I take my help from the Western world. Every Sunday morning, 8 o'clock, I have an international tumor board. Whenever there is a conflicting or difficult cases, I get help from the international experts. So telemedicine can be used for the educational purpose, tumor board purpose, and other things also. Thank you.
Thank you. Big hand for Dr. Vishnu. Arun Doctor, agiko kuralai ali resolution ko point ma confidentiality and all. Please.
यो मलाई अलिकति फेरि डाउट भयो फेरि जाने नभन्नु है फेरि डु वी हैव अ एक्चुअल भनौँ न एमओएचपी को गभर्नमेन्ट को कन्सेप्ट पेपर कि स्ट्र्याटेजिक पेपर कुनै पोलिसी पेपर अन टेलिमेडिसिन जस्तो यो मेडिकल काउन्सिल को गाइडलाइन रहेछ हैन दैट गाइडलाइन कम्स आफ्टर यु हैव अ स्ट्र्याटेजिक कन्सेप्ट पेपर हामीले नेपालमा हैव वी एग्रीड अफिसियली लिगली टु डु टेलिमेडिसिन अर नट हैन यो मलाई थाहा भएन हैन किनभने त्यो चिजै छैन भनेदेखि त्यो बनाउनु पर्ने हुन्छ होला नि त सबभन्दा पहिले
सो त हामीले रेकमेन्ड गर्दाखेरि त निर्देशिका भनिन्छ हैन, इङ्ग्लिसमा के भन्छ? Directive. So is there a directive? Okay, first, and how did the medical council come up with guidelines? It's more of ethical, you know. So directives, I am not sure whether there is or not. सरले बनाएको directive त अब
राजेन्द्र सरले भन्नुहुन्छ
कुरा आयो हैन। दोस्रो कुरा चाहिँ के छ भने जस्तो यसमा यो यसको यो गाइडलाइनमा के लेखेको छ भने registered medical practitioners भनेको मेडिकल नेपाल मेडिकल काउन्सिलको डक्टर्सले मात्रै गर्न पाउने लेखेको छ के हैन। सो इफ यु वान्ट दैट अब अहिलेको कुराहरु अनुसार विभिन्न स्टेजमा हो भने सो डिपेन्डिङ अन द टाइप अफ सर्भिस एन्ड द लोकेसन एन्ड अल दैट maybe you have to come make it broader into registered doctors मात्रै नभएर paramedics, nurses or whatever, हैन, even physiotherapy देखि लिएर सबै आउला, फार्मेसी आउला, के आउला,
इन्स्टिट्युसनलाई नै चाहियो नि खास
नै चाहियो हैन। सो यसमा त भन्यो भने त एक्चुअली anyone else doing it is illegal है, according to guideline, according to guideline,
okay,
हैन, but that's a guideline मा NMC ethical aspect बाट। तर गभर्नमेन्ट डाइरेक्टिभले टेलिमेडिसिन प्र्याक्टिस गर्न पाइन्छ भनेको छ कि छैन? फर्स्ट
भेरी इम्पोर्टेन्ट पोइन्ट,
फर्स्ट थिङ हैन। र छ भनेदेखि त्यसलाई अब यसमा के पनि लेखेको छ भने रेजिस्टर्ड, अब यो गाइडेन्स फर रेजिस्टर्ड मेडिकल प्र्याक्टिसनर्स भनेपछि रेजिस्टर्ड मेडिकल प्र्याक्टिस एक्सपेक्टेड टु हेभ बीन वेल ट्रेन्ड इन टेलिमेडिसिन बिफोर प्र्याक्टिसिङ टेलिमेडिसिन है। त्यसपछि नेपाल मेडिकल काउन्सिल स्याल डेभलप अर डेलिगेट a professional organization to develop a defined short course on practice of telemedicine with the help of experts working in the field of telemedicine in Nepal. Has this happened? So maybe you can recommend that this should happen.
Very important point. And you want to complement to this point?
So just a quick question. I think that one of the most important things from my experience in Australia is that in order for any kind of specialty, and the telemedicine looks like it's going to be a specialty on its own right, is to have a foundations. What are the foundations? Has Nepal Medical Association created a standard clinical manuals for the workers, for the health professionals? Is there a procedures manual? Without those two things, you are really not going to be able to build a house on it. So my suggestion would be, if there is already in progress, for our medical professionals, especially doctors and the academics, to come up with the standard clinical procedures manual as well as the clinical manual in the context of Nepalese demographics as well as the disease profile, and make it as applicable as possible for the workers in the remote areas.
Thank you very much.
So
Yeah, please.
यसमा एउटा दुईटा कुरा कस्तो छ भने क्रस बोर्डर टेलिमेडिसिन भन्ने छ है। We talk about international ICUs and all that, whether we are allowed to do this or not. So that part is also important.
Very important.
Your cross border भनेपछि anywhere. Border means across seas or everything. Privacy confidentiality ko ta Ryanji will also compliment on this. There are so many acts and all that we are supposed to know. To privacy or confidentiality actors, I think it is taken care of. म चाहिँ कन्भिन्स भएँ। तर पनि डक्टर्सहरूलाई सोद्धाखेरि त they would be reading all these acts. हैन, त्यो अलिकति सिम्पल टर्म्समा चाहिँ भोलि पर्सि भनिदिनु पर्छ होला।
ओके,
हैन, केले उ गर्छ भनेर कि अब सरले अघि भने जस्तो भुल गरेर त्यहाँ आफ्नै मोनिटर फोडेर त काम भएन, हस्पिटलमा ढुङ्गा हाने जस्तो हैन, केही भयो भने। तर देयर आर त्यो एक्टले पुग्छ भनेदेखि डाक्टर सुवासको सुरुको क्वेसन थियो नि लिगल कुराहरू, त्यो एक्टले पुग्छ भनेदेखि केही परेन, पुगेन भनेदेखि चाहिँ एड अन गर्नुपर्छ होला।
नपुग्ने चान्स नै आइछ डाक्टर मिङमा।
अरे त्यो एउटा नेपाल उसको चाहिँ नि क्युरेटिभ डिभिजनले एउटा कार्यविधि बनाएको छ, टेलिमेडिसिनको कार्यविधि बनाएको छ यहाँनिर। यहाँबाट उनीहरूलाई यो काउन्सिलको थाहा छैन जस्तो छ, काउन्सिल हामीले थाहा भएकोलाई उताको थाहा छैन जस्तो छ। देयर इज समथिङ। त्यो कार्यविधि पनि पर्याप्त त छैन, काइन्ड अफ एउटा सानो गाइडलाइन्स टाइपको चाहिँ बनाएको छ। र त्यो कार्यविधि चाहिँ प्रदेशमा पुगेपछि प्रदेशले आफैले मोडिफाई गर्छ, फेरि त्यो प्रदेशले आफैले मोडिफाई गरेर त्यसको त्यो गरेर युज गर्छ। त्यहाँ अहिले चाहिँ नि त्यस्तो के छ, के कार्यविधि छ त्यो पनि छ। Thank you.
Dr. Nitin, you wanted to add something? In brief, please. To the point.
Hello, धन्यवाद. म Dr. Nitin Bhandari, public health practitioner. अहिले चाहिँ डिजिटल हेल्थमा छु. एउटा कुरा यो हामी टेलिमेडिसिनको कुरा गरिराख्दाखेरि एउटा इम्पोर्टेन्ट कुरा चाहिँ मलाई के लाग्यो भने हामी बिचको अन्डरस्ट्यान्डिङ टेलिमेडिसिनको के छ. हामीले हेरेर हुन्छौँ कन्सल्टेसन भएको हेर्छौँ त्यो टेलिकन्सल्टेसन पनि टेलिमेडिसिनै हो कि अथवा हाम्रो विभिन्न प्लेटफर्म युज गरेर भनौँ न अहिले नाम नलिउँ विभिन्न प्लेटफर्महरू छन् ई-कमर्स प्लेटफर्महरू छन् त्यहाँबाट पनि कन्सल्टेसन भइरहेको हुन्छ त्यहाँ डेटा सेक्युरिटी यताउतिको कुराहरू त आफ्नै ठाउँमा छ तर हामी बिचको अन्डरस्ट्यान्डिङ के छ र त्यो हुनुपर्ने के हो व्हाट इज टेलिमेडिसिन यसको व्हाट डज इट इन्कम्पास है त्यो बिचको अन्डरस्ट्यान्डिङ चाहिँ हामीले एउटा सबैलाई अवेर बनाउनु चाहिँ जरुरी छ जस्तो लाग्छ र हामीले डाक्टर साहबले भनिहाल्नु यो इन्स्टिट्युसनलाइज गर्नुपर्छ भन्ने कुरामा त्यसमा कुनै पनि दुईमत छैन तर समस्या के छ भने टेलिमेडिसिनलाई मात्र इन्स्टिट्युसनलाइज गरेर हुँदैन हामीले डिजिटल हेल्थ इन लार्ज सोच्नुपर्छ र डिजिटल हेल्थमा काम गर्ने एक्टर्सहरू स्टेक होल्डर्सहरू जो हुनुहुन्छ एक ठाउँमा आएर अनि बल्ल सोच्नु पर्यो कि यसलाई हामीले इन्स्टिट्युसनलाइज कसरी गर्ने जस्तै अहिले हाम्रो स्वास्थ्य मन्त्रालयको कुरा गर्दाखेरि हाम्रो ह्युमन रिसोर्सकै कुरा गरौँ कतिजना त्यहाँ हुनुहुन्छ भर्सेस अस्ति एउटा कन्फरेन्समा हाम्रो कुरा भएको थियो राष्ट्रिय के अरे नेपाल राष्ट्र ब्याङ्कमा चाहिँ 40-45 जना त आइटी अफिसर मात्रै हुनुहुन्छ हजुरले यस सो यसले त एकदम इम्पोर्टेन्ट क्वेसन रेज गर्यो हजुरले ब्याङ्किङ सेक्टरमा हेर्नुहुन्छ भने देयर आर भेरी फ्यु सफ्टवेयर
मन्त्रालयमा 35 जना पनि भने
हजुर हो अब ब्याङ्कमा हेर्ने भने मलाई जहाँसम्म लाग्छ मेरो धेरै नलेज त छैन तर सफ्टवेयरहरू युज गर्ने स्ट्यान्डर्ड सेलेक्टेड सफ्टवेयर हुन्छ होला जसलाई रेगुलेट गर्न धेरै गाह्रो हुँदैन तर तपाईँले यहाँ स्वास्थ्यमा हेर्नुहोस् त यति धेरै सफ्टवेयर छ यति धेरै नयाँ निकालिरहेको छ हाम्रो कुनै पनि एउटा इन्जिनियरलाई भन्यो भने एक दुई रातमा उहाँलाई सर्भिस हुन्छ नि एप्लिकेसन बनाइदिनुहुन्छ होला तर इम्पोर्टेन्ट कुरा के हो भने हामीले जे बनाइरहेछौँ त्यो नेपाल सरकार अथवा स्वास्थ्य मन्त्रालयको प्रायोरिटी अनुसारको सिस्टम बनिरहेछ कि छैन त्यो पनि एउटा एकदमै मुख्य ध्यान दिनुपर्ने हो हाम्रो स्वास्थ्य मन्त्रालयले विभिन्न लेभलमा स्वास्थ्यका इन्टरभेन्सनलाई प्रायोरिटाइज गरेको छ डिजिटल नेपाल फ्रेमवर्कले पनि विभिन्न इन्टरभेन्सनलाई प्रायोरिटाइज गरिरहेको छ त्योसित हामी कतिको अलाइन छौँ त्यो एउटा कुरा पनि मैले हाइलाइट गर्न खोजेँ र एउटा अब आवश्यकता के छ भने डिजिटल हेल्थ टेलिमेडिसिन अथवा मोबाइल हेल्थ होस् म चाहिँ मोबाइल हेल्थबाट परेँ यो सबैको लागि हेर्ने एउटा डिपार्टमेन्टै खाँचो छ कि जस्तो लाग्छ
मन्त्रालयमै चाहिन्छ
एक्ज्याक्टली किन भन्दाखेरि डिजिटल हेल्थ सस्तो छैन न टेलिमेडिसिन सस्तो छ न डिजिटल हेल्थ सस्तो छ मैले 2012मा एक्चुअली बाजुरामा पुगेको थिएँ हजुर बाजुरा स्वास्थ्य अस्पतालमा चाहिँ त्यहाँ पुग्दाखेरि टेलिमेडिसिनको लागि एउटा रुम बनाउनु भएको रहेछ बन्द अवस्थामा थियो त्यति बेला अनि माकुराको जालीहरू सबै लागेको थियो अनि किन चलाउनु भएको छैन भन्दाखेरि चाहिँ त्यहाँ उहाँले सिसाट के राखेर त्यति बेलाको टेक्नोलोजी राखेर 2012को अनि सबै सिस्टम बनाएको तर के गर्ने यहाँ सेन्ट्रल हबमा बस्ने डाक्टर साहबहरू हुनुहुन्थ्यो उहाँहरू चाहिँ सधैँ आउनु हुँदैन त्यही भएर चाहिँ हामीले त्यो सर्भिस दिन सकेनौँ भन्ने कुरा थियो त्यो त्यति बेलाको समस्या थियो अहिले नहोला तर एउटा मैले हाइलाइट गर्न खोजेँ डाक्टर थिएन भन्ने कुरा हाइलाइट गर्न खोजेँ होइन मैले हाइलाइट गर्न खोजेको त्यहाँ इन्भेस्टमेन्ट कति भएको छ
ओके
त्यो इन्भेस्टमेन्ट इम्पोर्टेन्ट छ हामीले यहाँ कुनै पनि हामीले एउटा भनौँ न एउटा खोप लग्या जस्तो इन्भेस्टमेन्ट होइन यो एकदम महँगो इन्भेस्टमेन्ट छ बट एट द सेम टाइम 3-4 वर्षमा फेरि एक्सपायर पनि हुन्छ हामीले नयाँ किनेको फोन 5 वर्षपछि त पुरानो हुन्छ अथवा 3 वर्षमा पुरानो हुन्छ
हराएन भने
सो आई थिङ्क हामी यो कुरामा पनि एकदम इम्पोर्टेन्ट फोकस गर्नुपर्छ जस्तो लाग्छ र त्यही डिपार्टमेन्ट अन्तर्गत एउटा नलेज हब पनि बढ्नु पर्यो कि
गुड ल एकदम राम्रो पोइन्ट थ्याङ्क यू डाक्टर नितिन सिद्धु लास्ट पोइन्ट बाँकी छ ओके ल थ्याङ्क यू सो मच
अब लास्ट एउटा हजुरले भनेपछि र अर्को कुरा के भने स्वास्थ्य मन्त्रालय स्वास्थ्य सेवा विभाग सरकारको रेस्पोन्स रोल के हो त स्वास्थ्य सेवा मात्रै पुर्याउने हो अथवा रेगुलेट पनि गर्ने हो र यो रेगुलेसन गर्नको लागि पनि हामी जस्तो स्टेक होल्डर्सले चाहिँ उहाँहरूलाई अकाउन्टेबल बनाउनलाई चाहिँ हामीले चाहिँ ढकझकाइरहनु पर्छ र यो व्यक्तिबाट हुँदैन यो यस्तै टोलीले गर्यो भने मात्रै बल्ल त्यो कुरालाई हाइलाइट गर्नु
and as this is connected with both health and IT who will be the regulator exactly. That's a big question है त्यो पनि रेज गर्नुपर्छ होला थ्याङ्क यू नितिन अब in next 10 minutes maximum we are going to conclude the session अब यहाँ टेक्निकल पर्सन्स पनि हुनुहुन्छ कि हामी हेल्थ आइटी हो त डिजिटल हेल्थ भनेपछि पहिलो शब्द डिजिटल छ यहाँ राजेन्द्र सर हुनुहुन्छ पवन सर हुनुहुन्छ सुरेन्द्रजी हुनुहुन्छ अरू पनि हुनुहुन्छ होला सरी मैले चिनेको हजुर पनि ओके तपाईहरुको तर्फबाट आइटी को एंगलबाट के चाहिँ के इनपुट दिनु पर्यो त्यहाँ हजुर ए मुनिराज सर ओहो एकचोटि ताली बजाएर उहाँलाई फेरि सम्झौँ आइटी को पर्सपेक्टिभबाट पनि त केही त हामीले बोल्नु पर्यो नि त यस्तो हुनुपर्छ भनेर
What I say is IT is most important subject. Bina IT ko के हुन सक्दैन नि
जहाँ हावा छ त्यहाँ आइटी छ अहिले
हावा पनि चाहिँदैन इटोनी हावा इटोनी चल्छ As a matter of fact, मैले भने नि सुरु अघि पनि भनेको थिएँ I was not a doctor. I wish I was.
And you are almost doctor. अघि डाक्टर उदयले भन्नुभयो नि
Anyway, what I found, there is a close relationship between the technology, ICT, IC, whatever you call it, and other medical services. It should be married. It should be technical in engineering form, and also the telemedicine is equally important.
Right.
Is the technical know-how and video conferencing, all that you have to know. And medical
heart and lungs जस्तो
you have
lungs लाई heart चाहिने heart लाई lungs चाहिने okay okay Rajan sir any input particularly in connection with the IT perspective
अब यस्तो छ आईटी को मा त अहिले बिना आईटी त केही पनि सोच्नै सकिन्न we cannot imagine behind the IT. So let's make it more simple.
Okay.
Let's make it more simple. Nepal Medical Council ले आफ्नो प्रोफेसन को हिसाबले उहाँहरूले जुन कार्यविधि बनाएर उ गर्नुभयो टेक्निकली अहिले मिमा डक्टर साहबले भने जस्तै हामी क्युरेटिभ डिभिजन हाम्रो पब्लिक हेल्थ एक्ट आईएचएमएस रोड म्याप यी सबैले र अहिले हाम्रो जुन डिजिटल नेपाल फ्रेमवर्क र हाम्रो आईसीटी पोलिसी नेशनल आईसीटी पोलिसी जुन छ यो सबैले रेस्ट्रिक्सन धेरै राखेको छैन मैले त्यही भएर भन्छु धेरै रेस्ट्रिक्सन छैन तर यही हो कानुन पछि लाग्यो भने रविको पद चट गरिएर जान पनि सक्छ कानुन भन्ने त्यस्तो कुरा हो है त्यस कारणले गर्दाखेरि त्यो अब कानुनै कोट्याएर हेर्ने हो भने त एकदमै कम्प्लिकेटेड हुन्छ तर हाम्रा विशेष गरी हाम्रो डिएचएस मन्त्रालय त्यसपछि आईसीटी पोलिसी डिजिटल नेपाल फ्रेमवर्कले मलाई लाग्छ कहीँ कतै पनि त्यस्तो खालको
चेकबार छैन
र इभन क्रस बोर्डरको कुरामा एउटा स्ट्यान्डर्डाइजेसन त छ त हाम्रो प्रोफेसनमा त डेटा सेक्युरिटी हाम्रो प्रोफेसन जो इन्जिनियर हुनुहुन्छ त्यो इन्जिनियरले आफ्नो डेटामा लिकेज त कुनै पनि हाल्नु उसको प्रोफेसन हो नि त्यो त त्यस कारणले उसले कहिले पनि गर्दैन त्यो उसको प्रोफेसन हो उसको जब हो उसको बिजनेस हो त्यस कारणले त्यसमा धेरै ओरी भइरहनु पर्दैन तर ल्याकिङ चाहिँ के हो भने जसरी फाइनेन्स इन्स्टिट्युसनहरूको फाइनटेकको चाहिँ नि एउटा जुन रेगुलेटर बडी राष्ट्र ब्याङ्क भए जस्तै त्यो हाम्रोमा चाहिँ ग्याप छ त्यो चाहिँ एकदम स्वीकार्नै पर्ने कुरा हो त्यो चाहिँ ग्याप छ
रेगुलेसन
होइन त्यस कारणले गर्दाखेरि त्यो रेगुलेसन रियलाइज पनि भएको छ ग्याप पनि छ होइन अहिले डाक्टर नितिनजीले भने चाहिँ गरी हामीसँग टेक्निकल पिपल्सहरूको ल्याकिङ छ 14-15 जना कुरा गर्नुहुन्छ 2 जना पनि विभागमा त आईटी को जम्मा 2टा मात्रै दरबन्दी छ अब भन्दा पनि हुन्छ हैन मन्त्रालयमा 1 जना मात्रै
दरबन्दी बढाउनु पर्छ नि त पोइन्ट आयो नि त रिजोल्युसन हो नि एउटा
हुँदैन ओके एउटा डाक्टरलाई एमएसपी ले प्राविधिक भनेर 1.5 लाख 2 लाख तलब दिन्छ भने एउटा आईटी को इन्जिनियरलाई 45,000 को तलबले बस्दैन त्यस कारणले आईटी पनि प्राविधिक हो उसको पनि सरबन्दी बनाएर सोलुसन हुँदैन त्यसलाई चाहिँ नि अर्को लाइनबाट ल्याउनु पर्छ प्राइभेट कम्पनीले इन्जिनियर पाल्न सके तपाईको राख्न सकेको छैन त सरकारले कहाँ सक्दैन त्यस कारणले गर्दाखेरि मैले के भन्छु भने यसलाई रहेका कानुन मौजुदा कानुनहरुमा टेकेर जाँदा
यसलाई नै सिन्थेसाइज गर्नु पर्यो
धेरै कम्प्लिकेटेड छैन जस्तो लाग्छ मलाई चाहिँ है
Thank you. We're almost towards the end. Would like to listen to our Japanese. Okay, Pawan sir, you want to add something? Okay, namely, Feri. मुसुक हाँस्नु मात्रै भयो उहाँ सधैँ हाँस्नुहुन्छ
Thank you, sir. And I second what Dr. Nitin said just now. So we have to be clear with the definition, because what we are doing is teleconsultation. It's not telemedicine. That's what we think from IT perspective. Okay, so that's, I think, from today onwards, why don't we call it digital health initiative? Okay, so that's one thing. The other thing is, it's very sad to learn that like we came up with a directive after COVID situation, and we are still defining the telemedicine service as to provide table, chair, computer, web camera. And we cannot go beyond that. And it's very saddening for us in terms of IT, because like when we think of digital health initiative, we think of digitization of the medical services.
Yes.
And digitization of, we've been talking about health informatics, and those things should have been come there. Not just table, chair, table को है कुर्सी चाहिए एउटा अपरेटर चाहियो अनि एउटा भिसाट चाहियो एउटा इन्टरनेट चाहियो अनि एउटा राम्रो खालको वेब क्यामेरा चाहियो अरे that's not telemedicine. Thank you.
Okay, now to input ladies बाट एउटा पनि input आएको छैन है. We have noticed that. Please, anyone to volunteer or else? Okay, would like to take this. Oh, Dr. Rajani. No.
I think I have been speaking lots of things, but still I want to represent female voice as well.
Tali.
Okay. Actually, I would also like to add the human resource point. So I think the people with health informatics background should come also in this point. And not only like we are talking all these things staying in this urban area, but there should be something that is not only from the top to bottom, but bottom to up also. So we need to also see what is the need assessment of this particular rural area.
Users group. Very nice point. Very nice
So
point.
I think that's my point.
Wow, thank you. Now, I would like to take this opportunity to listen to our international delegate. What's your viewpoint based on your experience in Japan and other countries of Asia? Would you like to provide some input to our government?
Government, okay. Very big. Very big, okay. Actually, as I said in my first talk, unfortunately, even in our country, telemedicine is not so popular. Even though we have our government push this tendency to all the people, including medical people and the citizens. But most of the doctor would like to take care of your patient in person. And also most of the patient would like to come to us. That's a big issue still. Unfortunately, even though the government subsidizes some support for the medical cost for online consultation and from patient, but not so expanded yet. So that I always say that the coverage of the cost is quite low compared to the in-person meeting. That is a big issue because now we should, and also patient have to prepare the equipment for remote care, right? Of course, the patient, only patient need is a smartphone is okay, but medical institute prepare the devices such as PC and also internet connection and also somehow the electronic health record or something like that. So sometimes these kind of the systems can be the barrier to push the medical institute to go to the telemedicine. So I just would like to ask the government to support financially. This is our first maybe.
यो चाहिँ छचोटि आयो यो point budget भन्ने चाहिँ.
And also the kind of advertisements. This should be the second. Even though we said the usefulness of the telemedicine to the patient, maybe most, not most, but not all of them believe us. But the voice from the government is quite important. Why is it so useful and how it is reduce the medical cost or how to contribute to your daily life. This kind of announcement from the government is quite important. Our government do not such kind of advertisement. This is, I think, quite big issue. And this is not the government, this is a kind of commercial companies. I would like to ask them to develop remote sensing devices. Comparing to the in-person meetings, and the very limited information can be available on site remote consultation from patients. So that is a big issue in Japan, especially in Japan. So I just the PHC as a kind of a box was introduced from my colleague in Kyushu University in his presentation. That is a kind of one solution. So if we would like to use that kind of remote sensing devices, we should have the help from nurses. Nurses in the rural area is essential to take care of those kind of patients. So that's why I'd like to have more good equipment, and I'd like to have more support from this nurses. I'm not sure this is a governmental issue or something, but I'd like to, if you'd like to install.
Thank you. Thank you. A big hand for him. Now, final question from the people who are online respecting telemedicine, presence.
Ravindra Bista sir or Navindra Bista sir, you are online, so do you have any comments? Yes.
Thank you very much, sir. A very good evening to you all. What I would like to request, if possible, let's have one course from this workshop for teaching master's students in health informatics or digital health, and even in medical field, even in nursing field, so that it will solve the problem of lack of human resources in the country. If we could offer any formal course at university and research centers, then this could be very effective way of capacity development of human resources in telemedicine. This is just my suggestion. I have no such any compliment. Very pleased to listen this reputed international conference in telemedicine. I'm sorry I could not join physically because of my so many teaching learning activities at university. I wish very best for this conference and grand success. Thank you very much.
Thank you. Mr. Sir from Ask Foundation, do you have any comments? Sir?
Yes, sir. Yes, sir.
Yes, Mr. Sir.
Thank you so much. I find it really interesting, the discussion, the way the discussion is going on now. I don't have a particular question, but I would like to wish my best wishes for this program. Thank you so much.
Thank you. Chang Chishong, Professor Chang Chishong from Taiwan, are you online? So do you have?
I think Satya has raised his hand. Maybe he can talk first.
Yes, Satya.
Yeah, I don't have any question. I just have a comment. Actually, the theme for this this year's telemedicine symposium is very good. I always used to talk about nurses' role in telemedicine because this is really very interesting and very important topic. So we are always neglecting nurses, where these services are very important, the telemedicine services. And nowadays we are having this artificial intelligence induced telemedicine services. Once this picks up, then nurses burden will come down drastically. And if the teams can work towards helping nurses, like now the latest software which we are trying to acquire now, that EMR and EHR, so a lot of benefits for the nurses. There's the system generated alarm system, which patient is sick, which patient is doing well, which patient need to be shifted to ICU. So all these systems are integrated in the EHR. Once these softwares are up and this becomes very easy for the nurses, and really I appreciate the thought of including nurses in the telemedicine. Thank you very much.
Thank you. Thank you, Satya. You have been always helpful for us. Okay, Professor TMSoN.
Hi. Hello. Yeah, it's my great honor to participate this ATS. I really learned a lot from you. And I think in here in Taiwan, although we, at some point, we also have many medical resources, and some people, and actually many people, willing to serve, to help other countries. So I think with telemedicine, we can provide the services through this kind of technical. As I know that, for instance, I have a friend, he's a dentist. His church actually is going to send him to Nepal next week, stay there to help the people. I think we haven't discussed about the dental. Actually, they cannot do much with telemedicine, but consultation or the health education is also helpful. At least we can do something better than nothing. So that's, I'm really hope in the future, our technology, our telemedicine can be very, have lots of opportunity, can cooperate between our country and in this region. Thank you very much.
Thank you. Actually, we are very excited that you will be here in Kathmandu, but because of the other problem, you couldn't attend. Thank you, Professor. There is Delhi are you online? Delhi Raj Acharya, sir. Delhi Raj Acharya, sir, and Jahir.
हजुर नमस्कार.
Delhi, sir. Okay.
नमस्कार, म दिल्ली राज आचार्य, अहिले चाहिँ जलजला गाउँपालिका पर्वतबाट छु. यहाँ सबैलाई न्यानो अभिवादन. म यसभन्दा अगाडि मेघदी जिल्लाको स्थानमा महावीर पुन सरसँगको यही हामी न्यू एरासँगै टेलिमेडिसिनको कामहरू गर्दै आइरहेका थियौँ. त्यसमा यो कन्सेप्ट चाहिँ राम्रो छ. हाम्रो भूगोल सुहाउँदो चाहिँ धेरै कुराहरूमा हामी पछाडि परेको देख्यौँ. अब यसमा यसका राम्रा कुराहरू चाहिँ आफ्नो ठाउँमा छन्, सबै राम्रा छन्, तर पनि केही कुराहरूले चाहिँ हामीलाई यो लङ लास्टिङ गर्नलाई समस्या गरेको हो कि भन्ने कुराहरू देखिन्छ. यसभन्दा अगाडिको वर्कसपहरूमा पनि म सहभागी थिएँ. त्यसमा केही कुराहरू निस्किएका थिए, जस्तै गभर्नमेन्ट सँगको संलग्नताका कुराहरू र धेरै कुराहरूमा चाहिँ हामी छलफल गरेका थियौँ. यसमा खास के भएको छ भने यो डिजिटल हेल्थमा हामी यो एनजिओ आइएनजिओ र विभिन्न प्रोजेक्ट बेसमा चाहिँ डिजिटलाइजेसन गर्दैछौँ. खास गरी अब हामी एउटा किसिमको डिजिटलाइजेसन गर्छौँ, कुनै एउटा इन्टेन्स पोकेको एनजिओ आइएनजिओले त्यही किसिमको डिजिटलाइजेसन गर्न खोज्दैछ. हुन त टेलिमेडिसिन र डिजिटलाइजेसनमा त्यति धेरै एकरूपता नहोला, तर पनि हामी पब्लिकमा पुग्ने स्वास्थ्यकर्मी अथवा जो भोलिन्टियरहरू छ उहाँहरू पुग्ने कुराले पनि पब्लिकमा इरिटेसनको अवस्था आइसकेको अवस्था छ. त्यसै गरी यसको राम्रोको लागि अहिलेसम्म खासै सरकारले हैन यो यसो गर्नुपर्छ यी हेल्थको लागि अथवा डिजिटल हेल्थको लागि अथवा रुरल हेल्थको लागि टेलिमेडिसिनका कुराहरू भनेर पोलिसीमै नआएको कुरा भइसकेपछि अब हामी हाम्रा हेल्थ वर्करहरू प्राय जसो हामी सरकारभन्दा बाहिर गएर गर्न सक्ने अवस्था नरहेकोमा हाम्रा सबै हेल्थ वर्करहरूलाई चाहिँ अब त्यसलाई समावेश गर्न र हाम्रा सरकारी जुन इन्स्टिट्युसनहरू छन् तिनीहरूलाई चाहिँ समावेश गर्नको लागि चाहिँ समस्याको रूपमा देखिएको छ एउटा. त्यसै गरी अर्को कुरा, अब हामी त भूगोलका कुरा, इन्टरनेटका कुरा, अब 5G 4G का कुरा गर्दैछौँ, तर हाम्रोतिर अझै पनि 2G GPS देखि लिएर यो GSM सिमहरू चलिरहेका छन्. ती कुराहरूले पनि इन्टरनेटमा चुनौतीहरू थपिएका छन्, भूगोलका कुराहरू छन्. अर्को मैले आफै काम गर्दै गर्दा र अहिले देखिँदै गर्दाखेरि चाहिँ हाम्रो जो यो अपरेटिङ गर्ने व्यक्तिहरू हुनुहुन्छ, स्वास्थ्यकर्मी अथवा भोलिन्टियरहरू, उहाँहरूको यो क्षमता विकासको कुरा चाहिँ सबभन्दा चुनौतीमा देखिएको छ. र एउटा सामान्य कुरा सानो नेटको कुनै एउटा आइपी बिग्रिँदा बित्तिकै अथवा एउटा सामान बिग्रिँदा बित्तिकै त्यसलाई चाहिँ डिस्कन्टिन्यू भइराखेको अथवा काम नभइराखेको अवस्थाहरू छन् र यी कुराहरूलाई पनि सम्बोधन गर्ने गरी अझ मुख्यतः सरकारसँग चाहिँ सहकार्य गर्ने गरी यत्रो टिमहरू हुनुहुन्छ, एकदम रेपुटेड डाक्टरहरू हुनुहुन्छ र मेडिकल काउन्सिलको व्यक्तिहरू पनि हुनुहुन्छ। उहाँहरूले सरकारसँग कोलाबोरेसन गरेर कुनै एउटा प्याकेजहरू बनाउन सक्नुभयो भने र सरकारसँगै सँगसँगै हिँड्न लागियो भने चाहिँ यसको विकास चाहिँ अलि राम्रो हुन्थ्यो कि भन्ने चाहिँ मेरो आफ्नो कुरा हो। र खास गरी यो पार्टनर एनजिओ बेस डिजिटलाइजेसन गर्न भन्दा पनि अन्य चाहिँ हाम्रो एउटै रोड म्याप बनाएर त्यसमा गर्न सक्यौँ भने चाहिँ हामी सफल हुन्छौँ भन्दै यहाँहरूको यो कार्यक्रम र यो राख्ने मौका दिनुभयो, धन्यवाद त्यसको लागि र कार्यक्रम सफलताको शुभकामना दिन्छु। धन्यवाद।
थ्याङ्क यू सबैजनालाई एक्टिभ पार्टिसिपेसनको लागि धन्यवाद। लास्ट पोइन्ट उता रोल्पा वा बैतडीतिरबाट के यसलाई कम्प्लिमेन्ट गर्ने लास्ट पोइन्ट हो अब यो प्लिज डाक्टर धीरजेन्द्र इन सर्ट रेजोल्युसनलाई ड्राफ्ट भइरहेछ सो एक्चुअली उहाँको लागि ताली बजाइदिउँ त बिफोर लिसनिङ टु हिम। ए ओके माइक।
Thank you, organizer, especially Uday sir, for giving this opportunity to participate in this program. Especially मलाई के इन्फर्म भएको थियो भने यो जुन अहिले जुन वर्कसप हुँदैछ यो वर्कसपबाट 2-4वटा जिल्लाहरू छानिँदैछ, जस्तो पेरिफेरीमा हब हस्पिटलहरूको रूपमा, जसमा एउटा बैतडी हस्पिटल पनि एउटा हब सुदूरपश्चिममा एउटा हब हस्पिटलको रूपमा एस्टाब्लिस गर्ने गरी प्रयास भइरहेको छ भन्ने मैले एनएसआईबाट थाहा पाएको थिएँ। अनि म यो प्रोग्राममा आउँदाखेरि पनि मेरो पनि त्यही छ। म त्यहाँ अहिले डिस्ट्रिक्ट हस्पिटलमा एउटा म एमडिजिपी हो, क्लिनिकल कोअर्डिनेटरको रूपमा त्यहाँ काम गरिरहेको छु। त्यहाँबाट ट्राभल चाहिँ यदि हामीले पेसेन्ट रिफर गर्नु पर्यो भने चाहिँ ट्राभल चाहिँ एकदम फार छ। इट्स टेक्स अलमोस्ट 6 to 8 hours to send patients to the other tertiary centers. So usually we have to see serious cases like we have to say even myocardial infections and cardiac arrest cases and different pulmonary related cases. So in those cases, these patients really need ICU care. So in the morning sessions, we have talked about this e-ICU and all those. So if this podium choose that hospital as a hub hospital, or if you can integrate us with you, then it will be a very help to us. So that's my point. Thank you.
We appreciate your affection towards the institution you have been serving. Okay, with this.
Thank you, sir.
Okay, Srishti, quick. Okay, quick points. Last out, Dr. Rana. Okay.
Thank you, Uday sir, and everyone for inviting me on this platform. As a student of healthcare management, अघि नै धेरै कुरा उठिसक्यो, मैले जस्ट ऱ्याप अप सस्टेनेबिलिटीको कुरालाई चाहिँ पोइन्ट आउट गरेँ हैन। देयर आर भेरियस EMR, HR, telemedicine, digital health softwares around, and what the question is, what are we doing for its sustainability? I'd like to add a suggestion, a point, just as a student. Couldn't our health insurance system or private insurance system incorporate digital health or telehealth into its OPD so that it could be sustainable in long run?
Very nice point.
Thank you.
Okay, let's wrap up. Okay, Dr. Rana last. Rana लेखिन्छ कि राणा बोलिन्छ कि राणा? Okay.
समस्तमा मेरो नमस्कार. I am Dr. Anwar Bogati from Rolpa Hospital. I have been working in remote station since 5 to 6 years. So from my personal working experience, the concept of this telemedicine can work wonders if we take it in proper path or in proper way, especially to remote area where we are working in extreme conditions and in extreme environment. So and different things are being discussed regarding laws, regarding budget, and everything has been discussed. So I don't want to go in those things, but for me personally, I came here in a view that I wanted to set up this telemedicine to my institution as well, because
wow,
it's a very far away, and one way travel only can cost 15 to 20,000 for that patient. So I want to reduce that economic burden in first place, and this telemedicine can be handy for those patients and as well as our personal growth also. So in that context, in according to need based, we have to start it from remote, and then we can come to RN in my personal view. So a small start can यसले ठुलो फड्को मार्न सक्छ, त्यही भएर सो हामीले स्टार्ट चाहिँ गर्नुपर्छ भन्ने लाग्छ। अब यसलाई ल मेकिङ कुराहरू छ, अरू कुराहरू चाहिँ हजुरहरूले अब मिलेर गर्नुहुनेछ। थ्यांक यू सो मच। यति भन्न चाहन्छु।
एकदम माहौल झन्झन तात्दैछ। डाक्टर मेङ्गर लास्ट पोइन्ट भनेर औँला उठाइराख्नु भएको छ।
उहाँहरूले क्वेसन उठाउनु भयो त्यो कारणले चाहिँ।
ओके,
बिकज रोल्पा भयो चाहिँ डाक्टर साहब बैतडी government telemedicine program जुन चाहिँ छ अहिले, whatever the government program, we have already conducted training for the doctors from the district, from those areas, and the idea is to look after all the patients admitted at the hospital. All the patients, not only one or two. All the patients would be seen by the specialist. I mean, I don't want to say they would be seen by the specialist, but they would be treating. Local doctors would be treating with the cooperation from the specialist, from general hospital, Pradesh hospital or the province hospital. And in the general hospital, there will be doctors sitting there, specialist, eye specialist, I don't know what other, so many other specialists. They will be sitting there. They will be looking after the patient of the 14 districts. Suppose this is gynecologist table. All the gynecology problem would come here, and she's going to look after this. And whatever question you have, that would be tackled right there. And another thing is, similarly, other specialties, and another thing is 24 hours is emergency. Anytime you have emergency at your emergency ward, that would be, you can contact the specialist at the Pradesh General Hospital immediately, anytime. Then and there, through the video conferencing, they would take care. They would help them. Whatever advice. There are things, more than 90% patients can be treated through telemedicine, but the rest of the 10%, they have to go somewhere. We can't do everything up there. So this is just the beginning, Mandy. The second step is, from there, it will be directly referred to tertiary hospital. Tertiary hospital. And from tertiary hospital, whatever treatment they provide, it will go back to the district hospital. So that way, all the records of all the patients would be in cloud. It would be there wherever they go all around, the records would be there. So that way it is being, we're trying that way. We have already conducted one batch training all over Nepal. All the 7 provinces I have been myself. It was 2 days training. I did myself, and only one province, number 2, I could not go, but I did through video conferencing. So that way it is coming on that way. Right now, the province number 7, Sudur Pasim province, they have also inaugurated. Okay, all the district hospital patient would be looked after by the specialist, and they are ready. They are anytime they will start that. So that is kind of information.
Thank you. Thank you, everyone, for your very active and enthusiastic participation. Now the floor back to Dr. Uday.
Thank you very much. Thank you. Actually, that is why this society is needed. That is why we have to knock the door of the government, knock the door of the regulators to push. And we always have to walk forward and then push them and pull them with us. So that is what our teachers have done, and that is what we'll be doing. So we don't have to be very much afraid of the rules and regulations, because we as doctors and engineers, we all know our professional values. So we have to respect that, and that is what regulation is. So thank you very much. With this, we would like to conclude, and we'll make a declaration from today. And tomorrow afternoon, 2 o'clock after lunch, there is a session with the WHO and government, and we will be presenting this declaration with the government personnel, and hope this will happen. And now it's very good that government people are also aware about the telemedicine, about the use of telemedicine. And there are like telecom authority, this Nepal Telecom Authority, NTC, they also have allocated budgets for telemedicine. And actually they don't know how to use this budget. And we are here to have this budget. So I think we will, in the years to come, this future of digital health, telemedicine is great. And this digitalizing the human resource, there are posts like digital nurse. So I was very happy to see in the online, there was one digital nurse. So she was online. So those type of posts is very good. So digital doctor, digital nurse, digital paramedics, those things. So we will be digitalizing, we'll be training, we will have curriculum, we will have trainings, courses, we'll have budget, so that this telemedicine, including telehealth, digital health initiatives will grow in future. Thank you. Thank you very much for this. Even for this afternoon also, there are so many people attending. So it's a rare happening. Thank you very much. Thank you all.